All right. Okay, we'll get Lara to chair the session and then we'll get started. And, I think if you guys have any questions about anything, just put it into a chat. And then as we go along, we can sort of answer any sort of questions that come into the chat. But, I think the plan for today is we'll aim to go through each question. We're not going to aim to actually cover each question in detail, but maybe just give like a broad overview of perhaps, what other concepts are, why I've graded it, how I've graded it in terms of, easy, medium, or hard, and also, how it sort of compares to sort of other questions in the past as well. All right. Okay, Lara, go for it.
We're going to talk about each of this question in terms of what was it, what is the difficulty of it? So, is it green, high pass rate with variation, or was it, in the yellow zone, the yellow zone was varied, but with a lower pass rate, or if it's red, so completely new or a repeat with a pass rate less than 20. And then we'll kind of identify it and link it with the learning objective, and then give a 1 minute structure or key objectives just to give people a guide as to how they go through it. So yeah, let's get started, Stan. So the first one, number one, neuraxial anatomy, answer in the separate booklet provided. Now, when you posted this up, Stan, I was like, what is this? This was a bit of a mystery to me. I gotta be honest.
Yeah, so this one here, this was all they had for question one on that 15-minute perusal time. And so you didn't actually get a chance to prepare anything beforehand, other than, as what was said before, in terms of what you could sort of label on a longitudinal cross-section, which we've seen before in the past. But this is going to be one of those surprise questions which they had, which is why I've labeled it red. In the answer booklet, after your 15-minute reading time, you would have a separate booklet with all these questions asked. And then there was also from what I understand, a pictorial diagram as well, where they wanted you to label these specific ideas or concepts.
Yeah, okay. So really, it's asking us to label the bony anatomy of the L4 vertebra, label the soft tissue anatomy around L4. What are the 3 posterior superficial landmarks for spinal anatomy? What are the 3 layers of ligaments passed through when doing an epidural? What are the 3 causes of epidural venous engorgement? Explain the mechanisms of these and implications of these on epidural and spinal anesthesia. And yep. This is very prescriptive, compared to the normal SAQ style, where it's just, it started with write short notes on something to then multi-part questions. This is very prescriptive.
Very prescriptive. And that's why I've given it a red, because it's a new question. I think that it's something that, you sort of think you should know something of, but just because of the way it's presented, it presents itself as a new sort of format. And I think that it would have probably presented itself as a challenge for most trainees there. So it is, I do consider it a new question, even though I think that if you sort of look back in the past, you may sort of see similarities with a different question. And if you click onto the next slide, La, there is a question in 2014, question 7, which was describe the local anatomy relevant to the performance of a lumbar epidural block. And this was a short answer question. So I think if you had prepared an answer for this, at least you would have some idea of the anatomy that this booklet would have wanted from your answer. And if you click the next slide, La, this is the learning objective. So the primary learning objective comes from BTRA 1.4, which is describe the anatomy of the vertebral column, spinal cord, and meninges relevant to the performance of central neuroaxial block with appropriate surface markings. And the secondary ones, which happen to be the questions later on, they were from SSOB 1.7. So they're an obstetric learning objective, and they describe the changes in the anatomy of the maternal vertebral column, the spinal cord, and meninges relevant to the performance of a central neuroaxial block, including epidural, spinal, and combined spinal epidural with appropriate surface markings. Now, I haven't got it on the slide here, but I have heard where this question came from. And what I'll do is I'll sort of show you on my screen here. They believe the question came from Anaesthesia. And from what I understand, this picture here, figure 13 came up. Is that right, Jacinta? This picture, very similar?
That's correct. Yep.
Yep. Did they ask you to label almost everything that was there, or?
Not that much, no.
Okay.
Probably about 6 or 8 things perhaps. And then the bit on your red slide before where it was where you were talking about what are the causes of venous engorgement, we had to write an answer. It was for the mechanism of loss of resistance.
Yep. Yep.
Yeah. So 2 spotters of the epidural, talk about the surface anatomy, and then talk about the physiology of loss of resistance.
Great. So yeah, new question. And I think this was another one that you also had to label as well. What are your thoughts about that question, La? What do you think?
Yeah, look, I was just thinking, how is this ANZCA going towards being more objective? Like, if you look at this, you either know it or you don't know it. There's no real clinical judgment here. It's do you know anatomy about stuff? And I kind of like the fact that a lot of us have studied spinal anatomy. It's a really fair question, and a lot of us, I think, would have been asked during our training, what are the layers you go through when doing an epidural or spinal? We have to know the landmarks. I kind of like the fact that this is just a very objectively, you're either right or wrong with this answer, and there's just very little room for opinions of the examiners. And can you imagine the feedback for this is literally, here's the diagram, there's the answers, and over time, over space, it's not going to change.
Yep, agree.
Have you heard that? Are they going towards a more objective model? This is so different.
Yeah, interestingly enough, some of the anatomy questions in the past have been like this. So I know that there was an airway question, and there was also I think there was like a venous cannulation with the internal jugular, and very similar, that they would provide you with a picture, and then you had to label it, and then they would ask just a couple of concepts related to the applied anatomy of it. So we move on to question 2.
Question 2, describe the physiological effects of insulin. And again, this was a variation with a 20 to 40% pass rate of the 2009 B11 and 2000 B7 questions. Describe the role of insulin in fat metabolism and outline the actions of insulin that affect fat metabolism.
Yeah, so look, I put this one as a yellow here. And obviously the variation of the ones that you saw previously in 2009 and 2000, they're specifically on fat metabolism. And I think that if you went through this question and had a sort of a answer to it, you would have covered about, I reckon, 75% or 80% of that question. The only thing that's different of that is that they're asking about the physiological effects. So more than just with regards to fat metabolism. And certainly, another thing that you can incorporate with that answer is the effect of potassium and the use of insulin with regards to lowering potassium through the sodium potassium exchanger. So that would be one that I would also add into this question, which you probably wouldn't cover in the repeats. I think what is really interesting, Lara, is that if you saw the repeats, they were 2009 and 2000. So they were heading to questions over 10 years ago. And I think that is a really important thing to make note of, because this will be a very sort of similar theme that you'll see occurring, but, another 2 more times throughout this exam.
I mean, it really seems like there's no getting out of it. Like, you just have to do a lot of your previous short answer questions from a span of 10 years and then you're ready.
Well, yeah, no, but this one is over 10 years ago. So I've always said just do the last 10 years, which is 20 papers, 300 questions. But it looks that they're extending that a little bit further out now. So just be aware of that. And, look, the other way I guess you could sort of cover it is if you go to the next slide, La, and you look at the learning objectives. And I think that, if you were to cover the learning objectives, yes, you could possibly write an answer to this. And the primary learning objectives here was BTP or 1.85, which is explain the control of blood glucose. And then the secondary ones, B2P or 1.9 was describe the pharmacology of insulin preparations. And I think if you had a model answer to those learning objectives there, you could certainly apply it to this question here. So with regards to the pharmacology of insulin preparations, what you would specifically be applying to in terms of this answer would be the pharmacodynamic effects of insulin.
Mm-hmm.
So yeah, so those are the first two questions. So you got a hard one, and then after that, you've got a intermediate one. And then the third question here.
Number 3, outline the factors that influence recovery and reversal following non-depolarizing neuromuscular blockade. And so, yeah, again, this is a repeat of a couple of different years, 2015 A13 and 2012 A4. And yeah, you can talk about the learning objectives then.
Yeah, so this is a word for word repeat, straight out from those two papers there. And, you would have certainly got a model answer credit for that if you covered the last sort of 10 years. I guess one of the really hard things about this question is because it's such a specific question, factors that influence recovery and reversal. And you can see that the pass mark was between that 20 to 40%. So in other words, that the expectation of the amount of content that you need to write in is, I think, a lot more than, what you would probably expect from something that's a little bit more, I guess, specific or a little bit more harder. And, you would say that this sounds like an easy question on paper, but I think because of the broadness of it and because of the amount of content that they want, that is what makes it an intermediate question. And you can certainly see that from the pass rates in the past. Now we've got a question that says the 2015 repeat specifies rocuronium. Yep. And I think that is something that would be applied to the same sort of concepts here, except this one's obviously a very general one. So you can include things that may affect rocuronium and things that may affect, your benzoisoquinolineiums, such as atracurium. And the learning objective, so the primary ones is BTGS 1.38, describe the adverse effects of neuromuscular blocking agents and factors that may modify responses to muscle relaxants. So this is directly from that learning objective. And obviously the secondary ones, BTGS 1.36, describe the pharmacokinetics of neuromuscular blocking agents, and BTGS 1.39, describe the reversal of neuromuscular blockade using anticholinesterase agents, anticholinergics, and sugammadex, and the physiological effects of reversal. What are your thoughts on that, La?
Yeah, I mean, I'm just looking at the question. It says recovery and reversal. So it really looks like it's a two-part question of, physiological kind of recovery stuff, as well as potentially the pharmacology of reversal itself. So yeah, there's a lot to put in there. And again, I think I would, when I've got a really, really big question that seems to span quite a few different topics, I think having, just really outlining your answer really well, putting headings on each of the pages, so you're going to cover the band of this many things, but I've only got 10 minutes. As long as I've got those headings on each page, then I can, put my answers under it and make sure I've got a little bit. So, imagine I've talked about the pharmacokinetics of recovery, absorption, distribution, metabolism, and excretion, generally speaking of the agents, and maybe even put it in a table form for quick reference, and then write a bit about each and maybe the few points of difference between benzoisoquinolineiums and Hoffman and other non-organ dependent elimination and recovery, and then maybe put a couple of paragraphs at the back, which is reversible neostigmine and sugammadex. I'm just thinking that's potentially where I'm going with this. What in terms of do you think this is at all going to be worth a mention with neuromuscular monitoring? Factors that influence, I mean, probably not it's just factors that influence recovery. It's not really
it is a
talking
broad
about
question. And I think that if you did want to include that, I probably wouldn't do more than 1 or 2 lines on that, because of it's so broad. And as Billy was saying in the chat, the one that was repeated in the past was specifically to rocuronium. And I think because you had to include the other group of non-depolarizing neuromuscular blockades, which is the benzoisoquinolineiums, it meant that you do have to make sure that, you portion enough time in order to address that side of things as well. So, you might have had a model answer for rocuronium, which would be the aminosteroids. But then you also do need to make sure that, I would have apportioned, about 1 or 2 minutes trying to address some of the ideas in terms of the other factors that would, things like, as you said, affect like Hoffman elimination, okay, or ester hydrolysis.
Good.
Yeah. So yeah, tough question. So that's why it's given as a yellow for that one. All right.
And number 4, 40 mils of 0.75% ropivacaine has been given to a 60-kilo 80-year-old patient doing a brachial plexus block. A, what dose of ropivacaine in milligrams has been given? And how does this compare to the safe maximal dose? And B, briefly outline the features of the local anesthetic systemic toxicity, or LAST, which may develop. And C, briefly outline the underlying mechanisms of LAST. Do not discuss treatment. Quite a bit.
So if you go to the next slide, you look at, it's a variation question. And the previous variation questions have had very high pass rates. So the last one was 2019 A8. And instead of 40 mils of 0.75, you got 20 mils of 1% ropivacaine is inadvertently administered intravenously over 15 seconds to a 60-year-old, 60-kilogram woman. Describe the potential complications and mechanisms of this. Do not discuss treatment. Again, the previous variations didn't specifically ask about local anesthetic systemic toxicity, whereas this one specifically identified that as one of the main concepts you had to discuss. And similarly, in 2014, B6, 20 mils of 0.5% bupivacaine is inadvertently administered intravenously over 15 seconds to a 60-year-old, 60-kilogram woman. Describe the potential complications and mechanisms of these. I guess the only difference with this is that this is a much elderly patient, and whether that has any sort of implications that you could think about with regards to how you would answer this question versus the variations that were asked in 2019 and 2014.
Do you find it strange that they've given, instead of 1% which would be easy maths, they've actually given you 7.5 milligrams per mil times 40. So you actually have to work that out very specifically, and which is not the hardest thing to do. But I feel like ANZCA has always said this is not an exam of mathematics. And I remember in my exam, I was about to try and calculate something, and it's on, and this isn't a maths test. Let's move on. And this is just a little bit more than it's a little bit more,
isn't it? I agree. 7.5 times 4 plus 10 times 10 would be the maths that you had to calculate, and not as straightforward as what I always say in terms of that, any sort of multiplications would be by 2, 10s, or 5s. So,
and I mean, if I was just in my head, because it's a bit unusual, I think I'd just do, 7.5 milligrams per mil. I'd just go 7 times 40, and that's 280, and then 0.5 times 40, which is 20, half of 40. And that way I can easily add those together to give me 300 milligrams. I think that's probably how I do it, because I don't have a calculator, and I don't really want to be doing that on the paper.
I mean, the other way you could do it is just to do it as per 10. What is 10 mils? How many milligrams does 10 mils of 0.75 contain, which is 75 milligrams. Nice. And then, you can sort of work it out from there. 75 milligrams times 2 times, which is 150, and then times 2 again, which is, as you said, 300 milligrams.
Yeah, actually, everyone should know that. Everyone looks at a 20 mil pack and goes, "That's 150 milligrams." So
that's true. In fact, you're right. You're absolutely right. That how it's presented with local anesthetics, it comes as 20 mils of 0.75. Or sometimes it will come in 10 mils of 0.75.
Sometimes,
yeah, but most of the time will come in 20 mils of 0.75, which is, as you said, 150 milligrams. And then, very specific in terms of discussing about local anesthetic systemic toxicity. So this one here it's a little bit more defined in terms of what they wanted. I think the previous variations, they were a little bit broad with potential complications and mechanisms of these, whereas this one here is very, very focused. So look, I've given this a green light. I think that it's one of those questions, hopefully, that if you've had a good sort of setup for this question, even though it's a variation, you should be able to actually get quite a good answer out for this.
I like this. Again, just like that first question, they're getting, I feel like my particular problem with primary exam is just the broadness of the questions and the subjectivity of it. And at least this is a real movement towards, hey, do you actually know the answer or not? And we're not really worried about your ability to write a beautifully worded answer. So yeah, it's nice.
Yeah. And then we just quickly go through the learning objective. It's BTRA 1.3, which is discuss the pharmacology of local anesthetic agents, including mechanism of action, comparative pharmacology of different agents, toxicity, use of adjuvant agents to enhance the quality or extend duration of block, and pharmacokinetics of drugs administered in the epidural and subarachnoid space, but specifically BTRA 1.3, specifically on toxicity. All right, next question.
5, justify the dose of propofol you would expect to induce anesthesia in the following scenarios using pharmacokinetic and pharmacodynamic principles. A 75-year-old weighing 70 kilograms, and B, a 40-year-old weighing 70 kilograms with severe hypovolemic shock.
So really interesting one, this question, because this was a repeat from 2018 A7 and had a pass rate of 63%. What made it really interesting was that they made it slightly easier by actually removing one of the options. So in 2018, you had the same question, except you had a component of A where they asked you to justify it for a 4-year-old weighing 15 kilograms. And they've actually removed that component there. So you just had to answer the 2, which was the 75-year-old man wearing 70, and then the 40-year-old man weighing 70 kilograms with severe hypovolemic shock. So I find that really interesting because, despite this having a very high pass rate in 2018, they've even made it a little bit easier just by removing that the top one. And I guess, the argument for that is if you were going to discuss it as a weight-based basis, you would have applied the same sort of concepts for a 4-year-old child discussing about the distribution of propofol within the different compartments versus a 75-year-old man weighing 70 kilograms. So I think that's where they felt like, you were sort of discussing the same sort of concepts, but applying it into different scenarios. So as long as you could sort of discuss into one, that should show that you understand the ideas. And that would also include the idea of the effect of cardiac output and how it differs from a 4-year-old child and a 75-year-old man. What are your thoughts about this one? Like, very clinically based question.
Yeah, that's right. I was thinking, whenever they remove a question in the MCQs is when everyone gets it right or no one gets it right. So very poor discriminative value. So part of me thinks, oh, maybe there's just such a crazy variation in dosage of the kids or the justification that they thought this is embarrassing and we just can't afford to ask that question again. Yeah. But I think yours is more likely. It's testings. I almost feel like there's ideas, too much to talk about.
Yeah.
And the kids and the change in fun. Yeah. You've already, as in the child is already a variation of normal. Actually, B and C both are variations of normal in terms of they're an elderly person rather than a, standard middle-aged person and a hypovolemic shock. So you're now talking about complex things plus a child. It's just a lot to get through in 10 minutes. Yeah, I think that's probably why they removed it.
Yep. So yeah, I mean, and I think that if everyone had a model answer to that, and I remember my model answer to that. Would have included like a two-minute discussion on, the 4-year-old child. So, which meant that I guess you could either use that time for another question or maybe put a little bit more in for the patient with severe hypovolemic shock. Now, if we go to the next one, we can look at the objectives that were that's related to this question. So it's BTGS 1.3, describe and compare the pharmacokinetics of IV induction and sedative agents, the factors which affect recovery from IV anesthesia, and the clinical implications of these differences, and BTGS 1.3, which is the pharmacodynamics. Again, the thing with these learning objectives is, as you can see, there were ones that we had before, which were very specific. And these ones here, they're actually a little bit more broad because, it's about the pharmacokinetics and pharmacodynamics of all the intravenous induction and sedative agents out there. All right. So sometimes, I think it's, whilst I say you should try to have like model answers for learning objectives, this one here is it's a lot more challenging because this one here is very, very broad, unless you sort of break it down to specific intravenous induction or sedative agents. All right, number 6.
One. So number 6, discuss the factors that determine the time to awakening after cessation of a sevoflurane anesthetic. Red.
Yeah. Now I've given this a red one. Now did sort of cover some concepts in episode 41, washout of volatile agents, but that was specifically for the morbidly obese. This one's a completely new question because it's a very sort of general question. And it is related to the 2021 B15, discuss factors that determine the time to awakening after cessation of propofol TCI, and 2015 B5, which is describe how morbid obesity affects time to awakening after inhalational anesthesia. And I think that what you had to do was try to incorporate some of those ideas about what is the threshold at which awakening occurs and what can either increase that threshold or decrease that threshold, and then talk about the factors that affect it. And so you had to apply a lot of the ideas that you would have had for those two questions there and try to put it into this question here, which can be challenging when doing it for the first time. But again, a very, very clinical question that I think that most of us will encounter in our everyday practice.
Yeah. Again, it seems like it's always a big question because there's just so many factors, pharmacokinetic things and pharmacokinetic things you have to think about and talk about.
Yeah. I mean, you're absolutely right. Like this is a really big question. And I think that if this is where, you had to have really good structures for those two questions there, the ones in 2021, 2015, because by doing that, you could actually lean on some of the ideas and some of the structures in terms of how you're going about to answer this question. Because otherwise, you're right, there's so many things you can talk about. And again, it's very, very broad because there are a number of factors that you can talk about. But I think one of the traps would be just to talking about, one thing, which is perhaps, let's say, washout in terms of minute ventilation or cardiac output. But there's so much more than that.
Yeah, that's good.
And then we look at the learning objective. So this is PDGS 1.24, describe the uptake, distribution, and elimination of inhalational anesthetic agents and the factors which influence induction and recovery from inhalational anesthesia, including the concepts of partition coefficients. So you had to include that, concentration effect, second gas effect, relationships between inhaled and alveolar concentration, significance of the distribution of cardiac output, and tissue partition coefficients on uptake and distribution of volatile agents. Now, this is talking about the uptake, but certainly those ideas, depending on how much is taken up during the course of anesthesia, will actually affect the washout or the time to awakening after an inhalational anesthetic or a sevoflurane anesthetic.
I remember Stolting just had the best table, the most comprehensive table of the uptake, at least, which you could reverse in most of the circumstances for washout.
Yeah, I think they talk about the uptake and also intake as well, and they sort of separate it into key ideas where you've got the movement from this is for intake, where they've got the movement from the circuit to the patient, and then after that the patient, let's say the lungs to the blood, and then after that the blood to the brain. So yeah, you could also do the reverse engineer it in terms of thinking about it the other way as well.
Yeah.
All right. Question 7.
Discuss the factors that determine glomerular filtration rate, or GFR. Answer green.
Yeah, it's a very straightforward question, but I think that often the more straightforward the question is, again, the more you feel like you've got so much more to write. And looking at the repeats, so this came from, again, over 10 years ago. So this was in 2000 B8 with a 52% pass rate. Describe the factors governing GFR. So very similar questions. And then there was a variation of it in 2005 B10, 62% pass rate. Describe the forces acting across the glomerular capillary membrane. Explain how afferent and efferent arteriolar tone affect GFR. And despite renal being a very hard question, I think GFR hopefully will be one of those questions, especially if you apply Starling's forces or the Starling formula into it, where you could actually create a really sort of solid answer to this, which would get you a pass mark. And this is based on learning objective primary BTPO 1.63, word for word, describe GFR and tubular function.
Just remember, just knowing that one equation where you got forces in one direction and other than oncotic forces, so pressure forces, oncotic forces, if you just delineate all the factors for each of those, then suddenly you have an answer that just appears there. requiring very little memory.
You still remember that, don't you, La? Despite this being over over a decade ago, isn't it?
Only because of the we did the classified section in the podcast. Had to go through it again.
Yes, that's right. Yeah, you've got that.
You know, it's just like waking up from a terrible dream, isn't it? I had to remember
over and over again. All right, question 8.
Describe the role of carbon dioxide in control of ventilation. I feel like this is a question that just seems to come up over and over again, maybe because I'm teaching RESP all the time, but go for it. I
think it's because you're teaching RESP all the time, because if you actually look back, it's only been asked once before in the past, 2015 A2, outlined the role of carbon dioxide in the maintenance of ventilation. And during that time, it had a 30% pass rate. So look,
it's the other variations were the control of breathing. So yes, this is very specific. Yeah,
correct. You're right. So the other one was talking about the control of breathing. This one is very specific in terms of asking about carbon dioxide. So there is a way to answer this question because you had to talk about all the different factors that can influence CO2. So once you talk about sort of the effect of CO2, you talk about all the other ones, such as how your partial pressure of oxygen can affect CO2, and also how anesthesia as well can affect CO2 as well. And I think you could also include, you know, from that CO2 curve, things like metabolic acidosis and how it sort of shifts the curve. So there's actually quite a few concepts that you can apply to answering this question. I certainly go through it in my tutorial for respiratory physiology at the Melbourne course. And it is, what we sort of go through is a very, very comprehensive answer. And I don't think you need to include all the ideas that is described there. And, you know, I think the sort of the core component is really based on the mechanism of CO2. All right.
So you're saying, Stan, I mean, this question specifically asked about carbon dioxide, but you really had to go outside of that. pH, oxygen.
What you would do is you'd still talk about CO2, but you would talk about how it's potentiated or attenuated by certain scenarios. So we know that, you know, in cases where patients are hypoxic as well, we know that that's going to be potentiated. Whereas, you know, with anesthesia, you know, that is going to be attenuated. So I think you could add those ideas into this question here. And I think that, you know, there was a graph in nuns, which actually showed what happens with metabolic acidosis. So it's really interesting because, you know, if you were able to remember those curves that were there, there was certain things that would pivot the curve, and then there were certain things that would shift the curve. So, so a lot there to unpack. So yeah, it's an intermediate question. You know, it's been asked before in the past, and hopefully, you know, within the last sort of 10 years, you've got like a sort of a model answer to that. And, you know, you should be able to hopefully write something that would have been able to give you at least a 2.5, 3 out of 5. And the learning objective is BTPL 1.9, describe the neural and chemical control of ventilation via central and peripheral chemoreceptors and indicate how this is altered by anesthesia and abnormal clinical state. So yeah, as I sort of said before, anesthesia and then abnormal clinical state, the two that I would list if you had time is going to be hypoxemia or PO2 less than 60 and in acidotic states as well.
Yeah, excellent. Okay, red one. Compare and contrast the pharmacology of esmolol and labetalol with question number 9. And this is new, but it is related to 2001 A15 with a high pass rate of 75%. Compare and contrast the pharmacology of esmolol and propranolol.
Yeah, look, I thought about this one and I thought maybe I'll put this as an intermediate, but then I thought, okay, labetalol. I guess that's what makes this challenging. So even though this was a variation of the 2001 A15, esmolol and propranolol, they're very sort of similar drugs there. But now you're talking about labetalol, which has some alpha effects. And then, you know, to be able to sort of incorporate that into this answer, you might have got the esmolol bit, but then to be able to compare and contrast it with labetalol, I think would have been challenging. So that's why I've put it into the red section there. I think that, you know, for the trainees that set this exam, I'd be interested to hear your thoughts on whether you thought this was an intermediate or whether you thought this was one of the more difficult ones that you encountered during this exam. You can Jacinta or Billy, if you're there, let us know what you think in the chat. Definitely a hard question. Billy said. Yeah.
Yeah, I agree. Definitely hard.
Yeah, I would think so too. I
Definitely.
mean, you sort of look at it and you go, oh yeah, I know a little bit of esmolol, but then you go, oh, labetalol. Okay. It's again, challenging, because then after that, you need to go through each component in terms of the, dynamics and then the kinetics of labetalol.
Yeah. And really, that was we're not using labetalol that often. That was part of the reason it's so hard. We're just not studying in the same level as metoprolol, esmolol, and the cardioselective ones.
Yeah, I guess labetalol is used quite a bit in obstetrics. That would be my
in some hospitals.
Yeah, well, that would be my caveat, is that you do see labetalol used, especially oral labetalol, but you do see intravenous labetalol used for preeclampsia. I think what is hard for you guys out there, who've just started off with anesthesia in your first year, you're very unlikely to encounter a lot of obstetrics. I think that is more, you're more likely to encounter it in probably your second, third year. Wouldn't you say, like it's very, very, you might have the opportunity, but I think more so in general, you don't tend to get that obstetric experience in your first year as an introductory trainee and basic trainee. And
also, by the time the patient comes with severe preeclampsia to us, we're giving other stuff.
Yeah,
we're giving hydralazine and hopefully not SMP at that stage, but yeah, definitely less familiar. I mean, what hospitals I worked at, I feel like they only recently got IV labetalol, so I don't think I've ever actually prescribed labetalol IV to anyone.
I think I've only done it once. You're right. Normally it's oral, but yeah, I think I've only done it once. Do they have labetalol up in Broome?
I'm sure they do, but sabbatical, not really working too much in the hospital, unfortunately.
Oh, don't say that. You're meant to be working on your sabbatical. If everyone's listening, Lars working really hard.
Working on the sabbatical project, not clinical work.
That's right. All right, so we just got to go through the learning objectives. So look, the primary one is BTPO 1.54. Describe the pharmacology of commonly used alpha and beta receptor blocking agents, their clinical use, adverse effects, and use in the peri-op period. And the secondary objective is BTPO 1.58. Describe the pharmacology of antihypertensive agents and their clinical application, including the following agents: clonidine, alpha-methyl-dopa, alpha and beta blockers, which is your labetalol, nitric oxide, SNP, GTN, calcium antagonists, ACE inhibitors, angiotensin receptor antagonists, hydralazine, and potassium channel activators. Big one, big learning objective, but yeah, it's in there. So yeah, this will be a hard question. I reckon it would have been one of the more challenging ones there.
I love that. For one objective, learn everything about.
I know, it's so hard, isn't it? Like, this is really one of the challenges. Like I always say, in fact, I always get asked, how should you study for this exam? And I think the romantic answer is that you go through every single learning objective and you write like a comprehensive review of each learning objective. But you've got ones like this, which it's impossible. You have to break it down, don't you, to each of its specific components. And so, BTPO 1.58 doesn't just become one learning objective, it becomes 10, maybe more learning objectives.
I mean, that's why we did, I think we recommend different studying strategies slightly, right? Like I say, just do all the short answers first. But to be thorough, you really need to go through the learning objectives, but then you see this.
Yeah, absolutely. Well, I think that, look, if you had time, and that's the challenge, isn't it? Time. If you had, the perfect amount of time, you would go through all learning objectives as well as covering, a good amount of short answer questions, minimum, from the last sort of 10 years. All right, next question, question 10. It's a straightforward repeat. Seems to be come up every sort of 7 years. So 2015 B9, 2012 B16, 2004 A9. As you can see, 2004 A9 had a very, very low pass rate, but after it was asked, everyone's created some really nice templates for this question here. And you can see that the pass rate is consistently over 50%. And the learning objective specifically comes from BTPO 1.33, discuss the differences between the pulmonary and systemic circulations. And I think this would be one of those ones where, you could do it, most people would do it on a table. Like, as you know, I think tables are very hard to reproduce on the day of the exam because of the paper. And if you've tried it before, it is a challenge. And I think this would be one of the ones where if you had sort of a really good sort of template beforehand, you could actually just apply it to this answer here. And I think a table would work well as long as you've done it before.
It's almost like your table becomes a quarter of a table for each page.
Correct.
Because of the weird spacing, right?
Yeah, because of that 12 millimeter spaces, and it's only 21 lines, it really doesn't give you enough space once you start apportioning the page into it. And it's not even half here, because you do need to also put a third column in to describe what are some of the, like anatomical changes or pressure changes that you want to talk about, the key headings, and then talk about how they differ from each in terms of the pulmonary and systemic circulations. I mean, the other way that I talk about doing these compare and contrast is really just have the idea first and then talk about it in terms of how pulmonary is different from the systemic circulation. That would be a way that I sort of do a compare and contrast that is outside the table form. But again, that requires practice.
Yeah. Actually, for that one, I just remember trying to find a really nice diagram to show both circulations. And I felt that was visually a game changer for me. But I'm like, okay, I know how to draw a square in the middle with two circulations out on each side, and I can visually see the numbers to just help me remember everything.
Yep. And then you can do the calculations. If you can't remember the numbers, you can always just do calculations to work out, the mean pulmonary pressures, the resistance. That would be a way to do it.
Yeah, nice. Number 11. Describe the ionic basis of automaticity in the pacemaker cells of the sinoatrial node.
So this was a repeat question, and it's been asked before in 2020 A10 and 2011 B11 with very, very high pass rates. We did cover a portion of it in episode 2, cardiac action potential. So it didn't just cover the sinoatrial node, but we also covered the ventricular pacemaker, not pacemaker, but the ventricular ionic basis of how depolarization occurs in the ventricular myocyte. So this was just specifically asking of the automaticity in pacemaker cells in the sinoatrial node. So very, very specific for that. So that I think that, if you've done this question before, and certainly was in the last sort of 10 years, you would have a good sort of model answer. You need to have a good diagram with this. And the learning objectives that you would have covered is BTPO 1.43, which is discuss the physiological basis of electrical activity and its relationships to mechanical events, including the ionic basis of automaticity, the normal and abnormal process of cardiac excitation, physiological basis of the ECG in normal and common pathological states, factors that may influence cardiac electrical activity, and correlation of the mechanical events of the cardiac cycle with the electrical and ionic events.
It's a nice one. Like when I see that, it's an intimidating question after not doing much physiology for a long time, but it's a very limited question. There's only so much you can really answer there. So hence, I think the nice high pass rates.
And now question 12.
Yeah, classify diuretics, giving examples and briefly explaining their mechanisms of action.
Yeah, look, so I've given it a green. And the reason for that is that previously asked in 2003 and 2000 B10 and very, very high pass rates. But I guess the challenge is that this was asked over 10 years ago. And so, may not have had the opportunity to sort of cover this question beforehand. But certainly I think that, there is a lot of content to write here. And I'm quite sure that even though, whoever, the trainees on there who wrote an answer to this, they may have found this challenging because of the enormity of or the breadth of topic here. But I think that is actually a good thing, because that means that you actually know a lot. You know so much that you feel like, you don't have enough time to write everything there. And I would think that, in that whole process, you would have written some really, really good content for what you have down in terms of the different types of diuretics. And I'm
I
sure
think,
that, you would have been able to score like a 3 or 4 or even a 5 out of 5. And
I think you almost want a broad question, because then you don't need as much detail. Like having really high detail and stuff is probably a bit harder than just learning a little bit about many things.
Yep.
So maybe these questions are a bit more,
well,
I
I guess the challenge with this is that making sure that you had that breadth, because you could talk so much about diuretics and focus on loop diuretics or thiazides, but as you can see, the key thing is BTPO 1.82 describe the pharmacology of diuretics, and then the ones that I think the broad categories that you should include are mannitol, furosemide, thiazides, aldosterone antagonists, and carbonic anhydrase inhibitors. Those would be the key ones there. And then the secondary one is BTPO 1.81, outline a physiological basis of classifying diuretics related to their site of action. So I think, most people would show you a diagram of the nephron and then show you specifically where these diuretics primarily work at. That would be a way to, I guess, visualize the way that diuretics are classified. All right, question 13.
13. So 13A, describe the generation and features of a normal awake EEG. And then B, briefly outline the processing performed by EEG monitors, either BIS or entropy, to produce a single dimensionless number from the EEG.
Yeah, this is one of my favorite questions, because this is actually a question that I actually like to ask in the Vivas. But now that it's been asked in the written, lucky for you, Billy and Jacinta, and those who just recently set the exam on Tuesday, you won't be getting this on the Vivas, okay? But we did run through this in episode 36, and if you go on to the next slide, La, this was actually asked in 2017, question 4. It had a 23% pass rate, so probably on the lower end, but still 1 in 5 or more than 1 in 5 passed. And the learning objective, there's the physiological or the neuro one, which is BTPO 1.94, outline the basis of the EEG. And then after that, the secondary one is a measurement one. So BTGS 1.5 to explain the principles involved in the electronic monitoring of depth of sedation in anesthesia, including the use of EEG analysis. What do you think about this question, La?
I mean, I think there wasn't as much to learn in neuro, so I feel like this was, sleep and EEG was it wasn't too much that I felt like we had to learn. Just trying to think again, I like that they're breaking it up into very specific things, describe the generation and features of normal, and then outline processing performed. So I think, we probably all have done a summary on that, which you can try to reproduce. Yeah.
So I think, if you go back to episode 36, BIS and EEG, we talk about the different EEG waveforms and how they're produced. You need to have a definition of how EEG is produced. And then after that, we talked about BIS and how entropy works as well. And again, very specific ideas, but a lot of similarities between the two. And I think because of time constraints, you could just either use BIS or entropy. Do you use BIS or entropy up in Broome, La?
If anything, it's BIS. Yeah.
BIS, yeah. All right, question 14.
14, describe the maternal cardiovascular changes that occurred during pregnancy. And I feel like this is something that people cover all the time, especially when they're, seeing it in real action with pregnant patients as well. So,
yeah. And this was a repeat question, 2018 B5, where it had a 50% pass rate. And, I think we're getting a lot of these kind of questions, these applied physiological questions. So, describe the maternal cardiovascular changes in pregnancy, describe the maternal respiratory changes in pregnancy, describe the cardiovascular changes in obesity, the respiratory changes in obesity. Those are some sort of really sort of key ideas that the way the exam sort of evolving to. And based on the learning objective SSOB 1.1, describe the physiological changes and their implications for anesthesia that occur during pregnancy, labor, and delivery, in particular, the respiratory, cardiovascular, hematological, and gastrointestinal changes.
Nice.
And the last one, this is a hard one, I think.
Yeah, this looks bad, right? For number 15, using pharmacokinetic and pharmacodynamic principles, briefly outline the mechanisms of drug interactions, providing relevant examples. Wow. So that's that's one of the very specific learning objectives at the very start.
Yeah. So this was a new question, very broad question. And I think this would be one of the challenges, is because there's so much that you can include into this answer here. It is based on BTGS 1.19, describe the mechanisms of drug interaction. And I think with that learning objective there, you would have probably divided it into physical, chemical, pharmacokinetic, pharmacodynamic, but specifically this question was really asking about the kinetic and pharmacodynamic effects. And I think where you could break it down further into is that if you're talking about pharmacokinetics, absorption, distribution, metabolism, elimination, and the pharmacodynamics, I would think that you had to sort of talk about the things like the additive effects, synergistic effects, perhaps even antagonistic effects. I think that's the way that you would sort of broadly think about these ideas here, just off the top of my head, and then provide examples of each. So yeah, I mean, this was a tough question. I think you would have to have thought about it beforehand, because I think one of the traps would be that if you went, I think pharmacokinetics would have been okay. I think everyone would have gotten the absorption, distribution, metabolism, elimination. And I think the challenge obviously is during the pharmacodynamic principle, when discussing the pharmacodynamic principles, how do you divide that? Because I think the danger is that a lot of trainees would go by systems. So they would go cardiovascular, respiratory, CNS, when, it's probably trying to sort of focus on a more sort of broad idea in terms of, the additive effects, the synergistic effects, or the antagonistic effects.
Mm-hmm.
Anyway, yeah, hard question to finish off with. So yeah, that's the summary. Live, you want to go through it?
Yeah, so it looks like we had 7 green, which is really incredibly reassuring. 4 yellow, 4 red. The topics were anatomy, physiology had 7, so projection 1.5, endorenal, respiratory 2, cardiovascular, neuro 0.5, pharmacology had 7, and equipment, half of this question, so EEG. And here's a quick summary with the color codings as well. So there we go with the 4 reds, the 7 greens, and the 4 yellows as well.
Yeah, so this is like, I just do it just so that you can see what the flow is if you decide to do the questions from 1 to 15 in order. And if you did that in order, you'd be going from hard question, medium question, easy, hard, easy, medium, hard, easy, medium, easy, hard. And yeah, I think that there are different ways that you can approach this exam. I recommend doing 1 to 15 because I think it just takes away that cognitive load. But I do know a lot of trainees want to do it from easy to hardest. And I think that if you wanted to do that, make sure that you practice that, because the timings of how that occurs is different. What do you normally do for these questions? Like, do you go in order or do you go out of order?
I'll always go in order and just prep myself to know, okay, that's hard, but I've got 10 minutes to do it. I stick to time, finish the booklet, 9 minutes 30, switch over, just keep discipline that way. The extra cognitive load of having to organize answers, that's always going to be a problem for me. So I just don't even worry about that. I think going 1 to 15 means I don't miss anything accidentally. I did swap around with the MCQs for one of my exams where I looked at it and literally it was the first 50 were old, the last 50 were very recent from the last paper, and the middle 50 were completely new. And I definitely switched my order around, and I really stuffed up. I just did the wrong notation, and so I had to transfer it across and erase out the answers.
Oh, right.
Which was a risk. So yeah, hey,
Jeez.
Everything went well, but it's just that thing. If you haven't, like you said, if you haven't practiced it, if you haven't practiced it, then chances are it's not going to go perfectly well if you haven't done it before.
Yes.
Likewise, if you haven't done 15 questions in a row and have that the muscle strength and endurance as well. Yeah, it's hard.
Yeah. So on the final slide, I've just got some of my thoughts about this exam. That there's 4 new questions, 2 variation questions, where the last print was 2009B and 2019A. And then we had 9 repeat questions, where the last print was 2 from 2015, 2018, 2000, 2015, 2020, 2003, 2017, 2018. And if you go to the next slide, I've got some take-home messages. Look, I think this was a favorable exam for the trainees. If you sort of compare it to the one earlier in the year, they had 5 red, 5 yellow, 5 green. I think, as always, that, they do cover a breadth of topics. And I know this is one of the challenges of this exam, is that despite cardiovascular and respiratory being overrepresented with the learning objectives and how much you need to learn and how much you need to retain, they only present, 1 question each from this exam. So I think that just goes to show to you that you do need that breadth. Okay. I think what made things difficult, even though it's a favorable exam, what made things challenging for this exam is that 3 of the repeat variations were pre-2012, so over 10 years ago. So 1 yellow, 2 greens. And look, I've always said to review the short answer question papers from the last 10 years. In the first sitting, they would have given you a 70% coverage of all the questions here. This time around, it would have been over 50% coverage. And I wonder whether, the examiners are listening to how we break down these exam reports. And, they're slowly also evolving the way that they change their short answer questions as well. And so I guess the game plan is, if you do sort of, go ahead and look at how you're going to modify the way that you learn for the February-March exam. Look, I think it's still worth doing definitely the short answer questions from the last 10 years. But yes, I think that you have to expand now. And at least, you don't need to, I don't think you need to write model answers for all of the questions 2012 backwards. But at least I think have a look at some of them and also tie it into the learning objectives as well. And the last point is it's very rare, extremely rare for a question to be repeated from the last 2 sittings. So in other words, you can be almost certain, and I don't want to eat humble pie the next time I present this review of a paper next year, and that I think you can be pretty confident that you won't get a repeat from any of the questions in 2022. What were your thoughts on the exam, La?
I think it just feels very similar to all the other exams that we see. It's just a really great breadth of topics that, we obviously think certain topics are the big key topics and they seem to be examined, but there's just so many of the other minor topics that you just have to cover the breadth of everything. I think my preparation for my exam, just covering as many short answer questions as possible and learning those and repeating them and just really doing the exam practice plus constant variety with different timed questions to cover more topics, 3-minute questions, 5-minute questions. I think all of that would have been really useful for this exam. But also, I think it's really reassuring that they are going through some very specific questions. So it's much less subjective in a couple of those, and I do really like that. I just hope it goes that way far more so in the next few exams.
Yeah. And look, there is one other observation that I will make for this, is that the questions that appear over 10 years ago, they are very they almost feel like they're taken straight up from the learning objective. And look, I don't want to make any sort of hard and fast conclusions, but if you look at the ones that were asked over 10 years ago, it was insulin, GFR, and diuretics. And those could be tied directly to a learning objective. So I guess my observation there is that if there's a learning objective that has been asked over 10 years ago, that is probably something that you should review as part of covering the breadth and depth of topics that might possibly get asked in this curriculum. And maybe that's the tweak that you need to make. So, you know, again, time is never going to be on your side. And I think that, you know, if you had limited time and you just wanted to cover the last 10 years and you go, all right, what else I should cover? What I would suggest is any sort of learning objective that has been asked pre-2012, those are the ones that you also want to cover as well.